it's great to hear some of the more joined up thinking actually that seems to be becoming more mainstream than it was. And when I took on the role in Nottingham and Nottinghamshire, I was absolutely determined that we didn't lose the profile and the aim for the ICS to really stop just commentating about the health inequalities and start doing stuff to address them. And I think the NHS has commentated on them for long enough, and we need to be now doing something. So we thought about how we structurally built in an approach to health inequalities. We have a cross-system group, which is taking a leadership role in that. And that has very much brought people together to think differently and to make sure we do things differently. We are also one of the accelerator sites for the core 20+5, and we are really excited about that. What we also did was we repurposed our analysts to set up an intelligence and analytics unit, which gives now very, very granular detail down to practice and neighbourhood level to enable those really targeted things. And some of the really exciting work on how the vaccination programme developed our intelligence, ways of working to actually physically get into houses, look on the streets where uptake is low. We've also benefited from that as well. And we have committed to equity as a founding principle across our integrated care partnership with our local government partners as well. So we've tried structurally to hardwire tackling inequalities into how we work. We have had some quite challenging and difficult conversations because it is, as Bola said, it is a leadership kind of issue. And we have, our public health colleagues actually were really challenging about how the NHS works, because the way we approach universalism as a kind of, care for all, cradle to grave, was very crude actually in its sort of approach, not targeted enough. And so we've committed to equity, and then we've also committed to recurrently funding a health inequalities and innovation fund across the system, actually, driven very much by our places and neighbourhoods in terms of what they needed to focus on. And that was 4.5 million this year. Actually, each thing that we've done, there is a business case behind it. It does work. We know that we're in a very financially constrained environment, so we couldn't just kind of use money in a way that wasn't going to bring that back. And there are differential approaches, but a key one in this inner city of Nottingham, it's got some very similar population demographics to Birmingham. And then we've got the old coalfields across the middle of Nottinghamshire, which has a different sort of deprivation, a different disease profile, different population profile. But actually in both areas, we have quite significant cohorts of people with what we call severe multiple disadvantage. So it might, and if people have got 3 or more of these characteristics, then they are now able to have sort of much more targeted interventions. So that might be homelessness, drug abuse, substance misuse. It might be mental health. It might be adverse childhood experiences as well. So a number of those we've got some very, very vulnerable people, particularly in the inner city of Nottingham. And they now have a service which is recurrently funded, where one of the local charities coordinates the statutory services around the needs of those individuals, and it's had a massive impact in terms of their use of health services already. And through having the Health Inequalities Fund, they have got a substantive, they know now they can continue to develop that service. Another key area of focus through that has been the family mentor scheme as well, which again, it's about best start in life and getting underneath some of the issues and data that you've seen today. And then another key area for development for us is integrated neighbourhood teams. So it's great to hear some of the sort of developing thinking, because they are not NHS things. They are about mobilising community assets and having health as redefining how the health system works in partnership as civic partners, as public sector partners. So those are some of our key areas. I'll just give you an example of what we did around fuel poverty. We were all really worried about fuel poverty last year and the impacts on health, respiratory disease, hospital admissions, apart from anything else. And so what we did was we combined data, used our partnerships and our analytics unit to combine data. And 20% of Nottingham households were highly at risk of the impacts of fuel poverty, and 16% in the old coalfields across the middle of Nottinghamshire. So we looked at the lower layer super output area data that our public health colleagues helped us with. We looked at those households that would have fuel poverty, income and pension credits, and we linked that with GP data and looked at risk populations, particularly in the over 65s. And we found that 80% of people in that cohort had a long-term condition such as lung disease, or diabetes. So we specifically targeted those households. Each place did it slightly differently. And there was around 5,000 people overall in our population that were in that group. So in the city, they focused very much on financial social prescribers and getting people the benefits, the fuel poverty payments, debt management, winter fuel payments as well as we can. And that made a massive difference to uptake. In Bassetlaw, which is in the north of our patch, there was a huge, drive around getting people insulation in their homes, access to the benefits that they needed. So these were very much broader. They weren't specifically health interventions. They were broader impacts on health. But the health professionals also targeted these individuals for vaccinations and other things. So it was a combination of health and wider determinants of health as well. But we're also targeting not only sort of issues like that and using our partnerships differently, but we're also targeting the diseases that have the biggest impact. So that's part of our Core 20+5 work. And for us, our biggest cause of health inequality is smoking, actually. And so we've targeted smoking cessation, hypertension and frailty. And one of the improvement methodologies that was talked about in terms of the Core 20+5, what we've done is in areas of very high disease prevalent for diabetes, we've got an equity payment for those GP practices. So those GP practices have got differentially more resource to case find and treat diabetes, and that is having a really significant impact as well. So we're building our capability and our partnerships to have much more bespoke ways of working to tackle some of the wider determinants of health, but also the biggest sort of disease sort of burdens as well. We are also really focused on prevention. So we were really lucky, I think, because of some of our population demographics. We were one of the early runners with the targeted lung health checks thing. We used data very precisely about where we needed to position the vans, and we moved the vans around as well, so that we get the most at-risk population. And that is actually completely at odds with other screening programmes. The data on targeted lung health checks for early lung cancer detection is very different, and we've got, if you like, a differential approach in that we've got more people who've had lung cancer screening in the most deprived areas, which sort of bucks the trend of other screening programmes. And through that, we've detected 100 lung cancers earlier than we would have done otherwise at a pre-symptomatic stage. And we've also detected a further 20 cancers, mainly renal, through that screening programme. So we're sort of using a combination of approaches that we're building on and learning from all the time. Thank you.
Thank you, Amanda. So we're now going to move very swiftly to our panel. I'd like to, and you've heard enough from me today. So Catherine Pollard from Moderna. Catherine heads up research and development partnerships for Moderna here in the UK. Many of you will have heard of Moderna as one of the COVID vaccine companies. And last year they made a major investment in the UK and will be making significant investments to help support the UK become a global leader in mRNA science. So Catherine is going to take this panel.
Thank you very much, Angela. Such a pleasure to be here. And I'm actually, I think you've met four of the panelists, but I'm actually just going to invite Natalie to briefly introduce herself, as she'll be an unfamiliar face to those in the room. I have two questions, and then it's going to be over to you, to the floor, for the rest of your questions. So get your thinking hats on now. So Natalie, do you just want to briefly say hello and what you do?
Professor at the University of Leicester, and my specialism is health inequalities. I'm also the Director of Inclusion for the Leicester NIHR Biomedical Research Centre, which covers Northampton Hospital, University of Leicester Hospital, University of Leicester and Loughborough University. And my remit and essentially research focuses on all disease areas, all conditions and health inequalities. So really nice to meet you all, and I'm looking forward to our panel.
Great, thank you. So the first question, which was actually inspired by Natalie's question about the money. So I've been at Moderna for a year, but my background is the NHS. So I was in the NHS for 12 years, and I was brand new to clinical research when I started at Moderna. My first job was working in Tower Hamlets, working on primary care networks before they were national policy, and actually trying to work on increasing breast cancer screening with our very, very diverse communities back there. It was such a privilege to have that as my first NHS experience, and I worked with some of the kind of clinical and nurse leaders, whose philosophies, stay with me still very much to this day. But my point being that was back in 2010. And I feel like if you want to make a big change, and I think we all agree we need to make some big changes, you have to take a very long view in the NHS. And a long view, said as a former civil servant, is normally quite inconsistent with the way that spending review cycles often work and the way that some of our political cycles work. So I guess I just wanted to open up with a question, probably to Amanda and Bola first, about how are you thinking about recognizing the fact that to make some of the big reforms that we need is going to take concerted effort, large coalitions, and a very long term. But there's a lot of uncertainty about funding year to year. I don't know if you want to go first, Amanda, and then Bola?
Yeah, thank you. It's a really good question. And it was one of the very live conversations with our local authority partners, and our public health colleagues said the NHS runs on annual cycles. It's all very well doing these projects, but we can't really develop them, learn from them, build on them. And that's why it's in our integrated care strategy, and it's in our NHS sort of local plan as well, forward plan. We have committed to the Health Inequalities and Investment Fund, which we have committed to increase year on year, so that the services that we have commissioned through that fund know they've got a future. Having said that, we will keep evaluating them, and if there's a better use of the resource, we will do that. But we'll work with our neighbourhood teams and our places to reach those conclusions. So we see that fund, which will grow, as a route to do that. And I have to say, it's not loads of money, but the amount of energy, effort, enthusiasm it's generated has been absolutely phenomenal.
Great. Bola?
Thank you, Amanda. And I'm going to say two things. Mm-hmm. So there are two dimensions to the question, I think. There's something around when can you expect return on investment, and how do you sustain the investment? So the return on investment on health inequalities is actually not measured in years necessarily. If you think about cardiovascular disease, for example, the differential investment in hypertension case finding and optimal management and lipid optimal management in the core 20 plus population group will yield within 18 months to 2 years a reduction in stroke and heart attacks and the pressure on healthcare services. So I think there's a reframing exercise to be done to actually say that investment in reducing health inequalities is not necessarily measured in years. I think the second point in terms of the sustainability of funding, I want to salute Amanda. It's about leadership, because actually every integrated care board within their baseline allocation has something called the Health Inequalities Adjustment. And across the country, that is in the order of 1.2 billion. And that is not a question of year on year. That is in the baseline. And that's just the health inequalities. But if you think about the whole budget, primary care, secondary care, specialized commissioning, there's a health inequalities allocation factor across the entire budget. The question is, do you have courageous leadership like Amanda to say to the system, the money is actually there, let's use it for what it was intended for? That would be my comment on that.
Yeah, and I mean, all credit to Amanda for that. I think things have come a long way since I was back there in 2010, and it certainly means that I do feel optimistic. So my next question is about research. We know that the areas and organisations that are research active tend to have better outcomes. We also know that while we've seen some stark statistics about real disparities in healthcare outcomes, not only locally, but also across the country. And we know that is probably even perpetuated if you put graphs up that looked at the sorts of people that were participating in research. And so something we're really passionate about, and I know that Natalie and colleagues at NHR are really passionate about, is thinking about how we can make sure that the way that we do research is as inclusive as it possibly can be. So I'm going to invite Natalie to give her thoughts on some practical things we might want to do. And then I'll invite Matt, a colleague from the NHR, to also offer his opinion on that one as well.
I think lots of people ask me this, I think it's so much of what's already been said today. And I think I tend to give lots of principles, tips, advice. And I think one of the key areas, and I know Bola mentioned it today, is the distinction between equity and equality. Lots of my time is spent trying to show practitioners, clinicians, researchers, and working with different people from different groups and communities about taking a more individualised approach to that populational group. And what tends to happen, particularly in research at the moment, is we're saying we're tackling inequalities, but we're not taking an equitable approach. We're tending to focus on one group and assuming that group, that area, that location are all the same, and not recognising the intersections and the more equitable approach that needs to go into that individuals. And we say community, and we often say it quite broadly, but when you speak to people, they're not part of a community. They're communities within communities, and they're groups of people. So when you then take an approach, whether for my work at the moment is womb cancer, maternal equity, lots of different, and I work across all areas across health inequalities, lots of people say, well, I have multiple things that affect my life, which has been talked about today by many people. Disability, intersectionality at the core, disability, age, gender, ethnicity, race, my faith, my religion, all of those factors impact on multiple conditions. And sometimes what tends to happen is we work in silos, we deliver research in silos, and then one group and one area is tackled at one point. And I think it's about working in that co-production way, as has been highlighted by the Sharman Women's Centre, but also for all of us working together to try and move much more closer to the equity approach, I think. And there's so many tips and things and principles that we've all discussed today, but I think at the moment that would be one of my core pieces.
Brilliant, thank you. Matt, do you want to introduce yourself and add?
Yeah, thank you. So I'm Matt Brooks. I'm a gastroenterologist in Wolverhampton and clinical director for the CRN, the Clinical Research Network West Midlands. And I think to add to that, it is literally all the things we've talked about here. We've spent years in research describing inequalities and inequity and access to services and research, but we've taken so long to do anything about it. And I think all the things we've talked about here are all the things we should be doing in research and are doing, but in silos. At the moment, a lot of research that's happening across the clinical research networks is driven by investigators who have interests in those areas. So when you go to your organisation, your trust, there may be 3 or 4 silos of research activity, and that's driven by a principal investigator who has an interest. So what we've tried to do in the West Midlands is we've tried to map the inequity of access to research by trying to look at the underserved communities and populations. And by doing that, we've addressed the workforce issue, So we've gone back to our highest prevalent diseases. We've looked at the core 20 criteria, and we've started to fund researchers in the areas where we have the most prevalent diseases with the least recruitment. So diabetes in the West Midlands is a massive problem. 2 or 3 years ago, we were recruiting 20 patients in the West Midlands to diabetes studies. So we have specifically focused on investing in the workforce so that we can skill up new investigators in those research areas. And the other thing we need to do is we need to take research out of secondary care and we need to deliver it in the communities. And the only way we can do that is by talking to the communities who we serve. So the Community Connections programme that we collaborate on in the West Midlands with Birmingham Community Trust and the Black Country Community Trust is looking at that specifically. So talking to community populations that have not got access to opportunities to engage in research, to listen to them, to see how we can reshape research access in those settings. And that's been enormously successful, to the point that we're now getting researchers to embed working with community connections in their study design at the point of funding. And the final thing I think we need to do in order to try and win the hearts and minds of those communities is we have got to report research better. At the moment, a researcher will get their publication in Lancet and they will say, that's it, impact done. And I'm exactly the same. 15 years, all I've been interested in is high impact outputs. And then I met the South Asian community in Wolverhampton, and we worked with them to enhance the research of some of the outputs of our inflammatory bowel disease research. And actually what they wanted to see was artistic representation of the outputs of the studies. So we worked with artists to create a sari that was based on a histopathology specimen of a patient with Crohn's disease. And I tell you what, everyone who walked past that sari said, what is that? And it actually got the community talking. So we don't do that enough. Impact and output of research has got to feed back into those communities, and I think that'll really start to kind of win those hearts and minds.
Oh no, and thank you for that. That's definitely given me some more inspiration. Speaking from Moderna's perspective, we know that, the imperative during the pandemic was to get the research done quickly. We actually paused our pivotal COVID trial in the US because we didn't have a representative population. I think we're probably the only pharma company to do that. But we have so much more to do in terms of really, really making sure that we, the way that we go about things is in such a way that means it can be truly, truly embedded in kind of everyone's lives. So it's great to hear that. And it's only through working in partnership with colleagues here that we're going to be able to. So I'm going to, open up to the floor.
Good evening. I'm Connie Jennings. I'm the Director of Stronger Communities for WHG, a Place-Based Housing Association. You're talking my language today, at last. So the work that you're all asking to do, I've been doing for 30 years. And it's not new to us. So the Community Champion programme that I've been running for 20 years. You have this Core 20 Ambassadors programme, which I applied to, but because I don't work in the NHS, I didn't get through. If you keep doing what you've always done, you'll always get what you've always got. And my other plea is strength-based language. So I heard communities described as threatening and also difficult around vaccine take-up. We have to be really careful about how we describe huge groups of people that didn't take up vaccinations, may not have been able to get time off work, may not have had transport, may have had not enough information to make that decision, might have care responsibilities. So I just want to plea for strength-based, softer language when we're talking about people that don't attend or do not do the things that we think that they should do.
Sure. So thank you. Really important observations. And I'm sorry you didn't get through with the Core 20 Plus Ambassadors program. The thing that we were very clear about is it's professionals. And very early on, we made the decision that it's not just about NHS. So there are ambassadors that are not NHS employed. So it would be great to have a conversation about how we can work with you, because effectively what we're trying to do is create an ecosystem. And we're using some structures to make that happen. But actually, they're structures with very porous boundaries. So I get emails all the time from individuals who would say, what can I do to help? And I never say no. Because at the end of the day, the way to make this happen is to have a massive social movement. and that movement is not going to fit into my nice little ecosystem box. So let's have a conversation.
Yeah, I was just going to add, I really liked your talk. What all of the things that you mentioned that you're doing is lots of the work that we've been doing, particularly in Leicestershire around co-production, particularly with the work in womb cancer. Talking to women, we've found that most women, particularly black and minority women, don't know what womb cancer is. Many women, 100% of them, felt that the cervical smear test would tell you that all types of cancers, and that's not the case. And also signs and symptoms they're not aware of what they are. So similarly, we've had co-produced animated videos and animations that are now going out to community pharmacies, because many of the women in different communities have told us that the pharmacy is more accessible to them than the GP or a clinician at the moment. And also, coming back to Bola's point about digital exclusion, actually seeing an animated video similar to the SARI approach in a community pharmacy, and the pharmacist may speak a different language, or also is right on their doorstep, is more accessible than other routes. And so we've co-produced that with women. But also we've been able to access the ONS data, and we found that we were unaware in the UK that there's a higher risk for black and Asian women from womb cancer. We know this is the case in the US, but not in the UK. Now we've taken the data, and it comes back to how we collect and standardise our data. Uterine cancer was being kind of put in a box with another cancer, cervical cancer, and that meant that we didn't know that there was an inequality for black women. So the data now shows us that black women are at higher risk of womb cancer. But then when you talk to women themselves, the key feedback has been, well, if I don't know, then how would I know to go to the GP or clinician? But also, if I didn't know if I was at high risk, how could I take prevention strategies? But also, all the campaigns are people that don't look like me, and they focus on breast cancer. And we know with the prostate cancer campaign, since that campaign has been more targeted for different minority men, we've seen a huge impact on health outcomes, and now diagnosis has changed, late diagnosis. So it's about taking some of the great things that you're already doing and kind of translating that across the system.
Thank you, Natalie. Did anyone else want to come in on that one? No? Okay. Do we have more? The gentleman here in yellow, and then we'll go to the gentleman in the back.
It's a great panel, and I think it's a great day today. I think, I'm just delighted to hear, all the thoughts, and particularly the collaboration. The one point I want to make, I'm a liver researcher, and I work in that space for the last sort of decade or so. Health inequalities, particularly when it comes to, there is a lot of alcohol harm and the liver disease, and we know that those kind of facts, and particularly there are 4 times more deaths, particularly in those areas, what can we do to connect, the document, particularly I hear that when you're talking about asthma and the connection to alcohol, and the research point, which was made earlier, the areas where there is more deprivation and the research is not there in those areas. And I'm currently running 2 NIHR-sponsored studies. It's so hard to recruit in those areas. What can we do? How can we collaborate? Linking those 3 points, to Bola.
Well, Matt, do you want to take the first?
Yeah, so I think in terms of addressing those unmet healthcare needs, we have to prioritise funding into the areas where we need to. So the 2 main areas of poor liver outcomes at the moment are West Midlands, and I think it's Liverpool, Manchester, North West. And actually, I think there were proposals for those 2 regions to join up on bids, and I'm not sure whether it successfully happened or not. But then that doesn't address, so the funding flow, as you say, doesn't address the recruitment from the key criteria, the key participants who we need in those studies to enable us to have that generalizable data. So if we've got clinical trials, we want representative communities, so we've got generalizable data from the trials. And if we're recruiting from, with all due respect to Oxfordshire, GP practices or secondary care, you don't get that representable. So I think that's where working with the communities through some of the so some of the things we've heard about here, the Community Connections programme that we're working with Christine Burt's team on, and looking at ways that we can access those communities. So there are then, we need to get those communities to come in and challenge healthcare professionals and say, where's the research study? Where is my research study? So that then your principal investigators will say, oh, well, we've got this research study. So I think it's about us trying to link that up in terms of delivery with the communities who will help you to reach their participants.
Yeah.
I don't think it's easy.
Does anyone want to ask?
Yes, yeah. I think it's very important to get, first of all, there's taboos and barriers and stigmas to certain conditions, and I think it's very important to break those down, but do it in a safe space where they understand why that research is being done, what the impact of it's likely to be, how it's going to affect them as an individual, their family, the community. And once you get that message across, you'll get that engagement and co-production in research. And we're looking to kind of be involved in the kind of end research project in Leicester as well. So I'm really excited about that. How do we engage more Black, Asian, minority, ethnic communities within research, because they are underrepresented, and you don't get proper solutions that are going to work unless they are representative. So I think it's convincing them the importance of their contribution and giving that safe space and trust. It's about trust, being able to trust those individuals who are there, and then feedback. It's very important. What was the impact of that research? Not just put it on a shelf. I've had involved in so many research as a community leader, and spent hours and hours and really excited and not heard anything for like 18 months and saying, hold on, we're fine. Oh, yes, we published them. But, it's again, having that trust with the community leaders, and they're your key gate openers. They will, if people trust them, the community trusts them. So if you get them on board, then you've got your community on board.
Yeah. Great, thank you. And I just, one final thought for me is we've, for vaccine research, the most successful investigators we've had have been GPs, and GPs from really diverse communities. So we have this amazing GP from Blackpool. She's from Blackpool. She's like third generation, and all her patients absolutely trust her. And it means that we can, it's very easy to get into those communities. And so I think part of our objective will also be to support more primary care investigators. There was a lady at the back with her hand up.
My name's Janet Taylor. My background's in health and social care in Wolverhampton, but what I work as now is a consultant care and service user at the Faculty of Health and Wellbeing. And what you're saying about getting more people from certain communities involved, we've already got that. You see, this is the trouble. I think sometimes these things are already there. People just don't search for them. Do you know what I mean? I mean, if you click on the university website, you type in success and you'll see we've been running for 10 years and we're involved with everything across the board, from interviewing staff to interviewing students and going right the way through to graduation. So we're already part of that. And we're also people in the community where we can, there's people in the community that won't seek help, but we can reach them because they're people we know, they're people we trust. I've got neighbours who've got learning disability, autism, all that. It's me they come to because they know my background and they know the work I do, and I try and point them in the right direction. And that's what it's all about. It's not leaving somebody hanging, saying, well, perhaps go there or perhaps go here, and that's what it's all about. If you can help, why wouldn't you? That's always my motto.
It's a fantastic offer. Did the gentleman here, do you still have a question?
Hi, Callum from Project Engineer at Synoptics. I had a question. I've seen a couple of announcements in recent weeks about the use of AI in healthcare. Mm-hmm. Given that we know from extensive examples across various industries, AIs can accentuate and entrench the biases that are already present in the data that is input into them and the society, the wider society. How prepared are we for the impact of this on the work that's going on in equality in the NHS?
Do you want to take that one, Bola? I can help with my old job if you want.
I can make a start, but it would be good to hear other voices as well. But it's a really good question and a very important one. So I had the opportunity about 6 months ago of opening the Precision Medicine Centre at Bristol University, and I used my keynote to actually address the point that you're making around health inequalities, genomics, AI, and all these newer interventions. And I've been talking to Google. So I had the opportunity to talk to Google's Global Health Equity, Chief Health Equity Officer very recently to say, we've got a problem. And we need to consider the fact that the underpinning data for a lot of the algorithms are actually, for the most part, European and don't necessarily represent the global south, for example. The thing that was really exciting is that it's actually already on their radar. And so in terms of the big tech companies, I've already reached out to their, where they have it, their health equity officers, where they don't, whoever else we can have the conversation with. So I think we're alert and alive to the risk. But I think there's also another dimension, which is the great work that Khadija and Ari have been doing in Leicestershire around communities themselves. One of the things we realize is the trust question. Because even where there are opportunities for AI to narrow the health inequalities gap, sometimes the reason why the gap will be exacerbated is not necessarily by design, it would be by default because the communities don't trust these technologies. So I think it has to be a multi-pronged approach of putting it on the radar of government and policymakers and the big tech companies and the conversations we need to have with the communities themselves. But you're right, we are at the foothills of that. But I don't know if other panelists want to comment further.
It's not specifically AI, but I think the digital as we get more digital, and that becomes more around how people interface with health services. It's a bit for our digital strategy, we've got quite a big strand on digital exclusion and inclusion, and I think again it is working with the different communities and making sure that we have equity in that we're helping people to overcome barriers where there is digital exclusion. So that it's just as part of our thinking.
Did you? Sorry, you go.
I was just going to say, I think what would be really important, I think it's a great question. I think the other thing that could be a gatekeeper for making sure we consider this is ensuring that researchers have it on their agenda when they are co-producing AI intervention studies. And we already embed equality, diversity, inclusivity through the NIHR framework into trials, but I guess it probably wouldn't take shape in a lot of the AI studies. I've run AI studies before all of this, informing kind of diagnostic pathways and things, and it never struck me. So I think we do have to build it in, and as we redevelop sort of this, the digital exclusion aspects, we need to make sure it's on the radar of the investigators as it goes to panels for funding.
Yeah, I mean, I think to me the biggest thing is unconscious bias, right? And just blindly assuming that you've got, 5 million people in your data set, of course it's going to be representative. And that's not a true assumption. And I think the more data literate people can be, including, everyone who works in this space, to just even start asking the question of is this representative, are the people that will most benefit from whatever the solution is included in this. At least you can start to measure what the kind of gap is. There was a lady at the back, and I think this will be the final question.
Yeah, thank you. So I'm Claire, I work with Gilead, and it's really exciting to hear so much expertise in the room around health inequalities. I think one of the things that we've been trying to do, certainly nationally, but around the Midlands, is gather the patient voice so that we can truly understand what the experience is of the patient, but we're one step away from the patient. And so my plea to the ICB teams and the community teams is to gather that data and share it with us so that we can actually co-collaborate with you with the patient in mind. And I think it's great to hear that Janet's got that availability, and we can connect with groups like those, but also don't be afraid to publish the work and to share it with, you know, companies like ourselves, because the value of having the patient voice and the cross-patient voice across communities, across, you know, ethnicities, whatever, you know, the groups of patients. And the other thing is we have great experience with patient voices in the community. We work across drug and alcohol services, for instance, and we'd be happy to share that information with the ICBs. We've got community groups that do that. So again, it's co-collaborating, it's sharing this information so that we don't overwork our community groups, because I think that's often the challenge as well, is we're all duplicating work with individual community groups. So
it's a great point. I don't know, Amanda, if you just wanted to offer
Yeah,
reflection.
I completely agree with that. It's really good to hear, and I completely agree. And I think one of our roles is to sort of help bring people together so that they, and that's where I think the neighbourhood teams, the integrated teams, and the place-based partnerships are so important, because they can make connections and reduce duplication, because they know the local networks much better than we would, for example. So I think that the power of local relationships and networks is really important, and we should use them and help them to flourish so that they can do just that. Yeah.
Great. I'm just going to ask whether anyone on the panel wants any final reflections. But if not, I know that we have... please, of course.
If I may, for Virginia
Yes,
to offer a view, because your clinical leadership is stunning. And one of the things that I'm very conscious of is sometimes that's the problem, is that we don't have clinical leadership in the way that you've exemplified. And I just wondered if you could just offer a thought about how do we clone you?
I don't know that you'd want to.
But you know, how can we mobilize our clinical leadership in this space more? Just your thoughts. I'd appreciate that. Sorry to keep you from the drinks. Apologies.
So it's hard, isn't it? I mean, I'm desperately enthusiastic about what I do, and I think all the people I work with are desperately enthusiastic. And part of that, I suspect, is that we're in this vaccination bubble, and it is a wonderful, enthusiastic team to work in. But I think also part of it is because we have a budget, and we can therefore see a problem and straight away think about an operational solution to that. What can we do? We've got mobile vaccination vehicles. You know, we're going to send one into that area, or we need to send one to that community, but that community might not interact with us. Let's speak to Khadija, get her to lead the troops in advance. You know, we can operationalise and do a lot, and that, I guess, that's very rewarding, isn't it? Because you can begin to see the data change over the weeks, and you can see that actually the efforts you've made have had an impact already on the communities that you were trying to target and reach with your vaccination. I think for me, I mean, looking ahead, we're trying to redo our project this winter, and we're waiting at the moment for them all to get jabbed spontaneously. Then we're going to look to see the ones last year who were in our project. Did you get jabbed spontaneously this year? Because maybe that was a permanent thing and we've turned you over. But we're also trying to roll it out across our patch. And we've got issues with capacity in terms of how many vaccinators we could even pull together to run a project like that. But looking ahead beyond that, we're then thinking, well, are we just creating something which is going to drive our general practice colleagues mad? Because we don't know that we've got any budget beyond this year for A&I, our access and inequality funding for the vaccination programme. And there is a risk that we're just setting up a wonderful expectation that everyone with COPD will sit at home and say, right, well, let's just wait for that lovely nurse to come and give me my jab. Why should I wander down the road? So I suppose it's ring fencing those budgets, knowing that they can be guaranteed in advance. We generally, we get to probably the last week in March before we find out for certain whether or not we've got funding in terms of access and inequality funding. Half of our vaccination programme team will be out of a job if we don't have the A&I budget, because that's the only way in which we're able to keep the team financially afloat. So I think that those are the biggest things for me. If you've got enthusiastic people, look after them and trust them with those budgets, because if they care about their job and their populations, they'll make the right decisions and they'll do the right things to suit their local people.
Brilliant. Well, thank you so much, everyone. Let's give the panel a very
So thank you, everybody. we've lost very few of the audience. Thank you for staying. I know those that had to go, it was trains or children that dragged them from the room. I'm not going to pull together all the thoughts of today because you're all super intelligent enough to take away your own messages from today. I did just want to call out Claire's comment a moment ago, though. Gilead have really pioneered discovery in HIV and hepatitis C. And her new general manager, who came over from France 18 months ago, said to me, Angela, she said, how can we work with ICBs much better than we are doing so to help find refugee communities with HIV, with hepatitis C, because we are never going to hit the hepatitis C elimination program until we do that. So you talked about sharing data. Gilead have got a huge amount of data. And the other thing she said to me was one of the treatments that they brought out for breast cancer works better in the clinical trials in black women. And yet black women are not getting access to it in this country in the same numbers as white women are. White women with sharper elbows like me. So I just leave you with that thought about that collaboration back and open the door to these people because they can bring money, they can bring investment, and they can bring data.